Hi guys, we'll just give it another 2 or 3 minutes, wait for another few people to join, and then we'll start. Hello, everyone. Thank you so much for joining on a Thursday evening, probably after placement and lots of hard work today. My name is Holly. I'm a doctor at Aintree Hospital, and I'm going to be presenting this session. I've got Katie with me.
Hi, everyone.
And she's going to be manning the chat and the Q&A. So we'll try and keep this quite interactive, but also quite brief, as it's just a revision session, and your feedback has all said you prefer it when the sessions are a little bit shorter and more concise. So if you've got any questions at any point, put it in the chat or put it in the Q&A, and Katie will pick those up and answer them. So just quickly at the start, who are Thursday 15? We are a group of F1s based in the Northwest, and we're running hopefully brief revision sessions every Thursday that are mapped to your curriculum for finals to help you revise for finals. You can follow us on Facebook, and you can also follow us on Instagram. And I've just done a little bit of publicity there for when you pick up those slides. We'll do a feedback link at the end. Once you fill in that feedback link, because we do genuinely read all of your feedback and we respond to it and we try and make changes. So it is really useful for us if you fill that in. But once you've filled that in, you'll be able to put in your email address and we'll send you the slides and the recording. So this session is on ophthalmology, and as with every other session, there's going to be 15 questions in finals style. We'll give you a minute per question, so I'll just get my timer out. And if you grab a pen and paper or just your phone to make a note of the answers, the questions will automatically move on after a minute. So keep an eye on them. If some questions are a little bit shorter, I might just give you slightly less time so that the session's not dragging on too much. Make a note of those, and then we'll go through all the answers with some explanations afterwards. Okay, so let's begin. Okie dokie. Right, so that's all of the questions done. So what we're going to do is we're going to go through each of the questions and the answers to them. I'll put up a poll on the screen, and then if you can vote, just to try and keep it a little bit interactive and see how you guys have done with the questions. And then we'll go through the explanations. So question 1 is about a 56-year-old female. She's got a red eye, blurred vision. She's got halos around the eyes, around lights, and feels sick. She's got a fixed and dilated pupil with reduced visual acuity. She's going to be urgently referred to ophthalmology, but in between that review and now, what should the GP do? So let me just launch the poll for you. Okay, we'll end the poll there. So most of you have gone for A, a few of you for B, a few of you for E, and a few of you for D. So the correct answer was A. So the way I learned ophthalmology was just to categorize each presentation into sort of 3 sections, and then you can take your OSCEs or your finals questions and split them into one of these categories. And then all you have to do is ask questions to differentiate between all of the presentations in that category, if it makes sense. So those 3 categories are a painful red eye, acute painless loss of vision, and chronic painless loss of vision. So the first few of these questions are about people presenting with a painful red eye, sorry. I've just put conjunctivitis there in italics because it's not painful per se. Sometimes you could get a little bit of irritation and a little bit of grittiness, but it's not painful like the other ones are. So what diagnosis are we going for in this question? What do we think this patient has? Put it in the chat. Oh, actually, is the chat activated? That's a good question. Oh gosh, sorry, you're all having to put it in the Q&A. Give me 1 sec. I'll see if I can. Katie, do you know how I activate the chat?
I think I can see the chat, but I don't know if everyone can message in it or if they can just put things on the Q&A.
Wait, I've realised you're not activated, everyone. Sorry. I've now activated the chat so that we don't have to clog up the Q&A, but you're all right. And yes, Hannah, we're going to release the slides after you've filled in the feedback form at the end. So as you're all putting, yeah, we've got acute angle closure glaucoma. So the risk factors are hypermetropia, so that is long-sightedness. People who are long-sighted have a shorter eyeball. So obviously we know that acute angle closure glaucoma is due to an increased intraocular pressure because none of that aqueous humor is able to leave the eyeball, so it builds up and causes a pressure. People who are long-sighted have that short eyeball, so there's a smaller angle for that aqueous humor to escape from, which is why they're more prone to it. It's also seen in older people, they're female, and they might have a family history of acute angle closure glaucoma. As we've seen in this patient, they present with a painful loss of vision, nausea and vomiting, a reduction in visual acuity, and the classic sign is halos around lights. A lot of ophthalmology is recognizing certain descriptions of visual loss or visual changes, and the thing that you want to remember for this is halos around lights. So on examination, you might see conjunctival injections, so essentially that just means redness of the conjunctiva, a hazy cornea, a fixed non-reactive mid-dilated pupil, and a high intraocular pressure. And to investigate it, you're going to do gonioscopy and tonometry. Can anybody tell me what gonioscopy is? Yeah, great. So that checks the angle between the iris and the cornea. So obviously you'd expect a small angle in acute angle closure glaucoma because the angle is closing. And tonometry, what does that measure? Perfect, the intraocular pressure, which we know is going to be elevated in these patients. So how do we manage them, which is what all of this question is about. So analgesia, obviously they're in pain, they're nauseous, so we want to give them antiemetics. Lay flat. Now, does anyone know why we lay them flat? Because in the question, one of the answers was standing up, which obviously it isn't correct because you have to lie them down. Pressure intraocularly. Maybe that was to do with the previous one. No? Okay, so if you just think about gravity, if we lie someone flat, the angle is right at the anterior aspects of the eye. And what we're doing is we're moving that aqueous humor away from the angle. It opens up that anterior chamber angle and allows more drainage of the aqueous humor. So we've got to lie them flat, so allow gravity to work on our side. And we're going to use both systemic and topical pressure reducing agents. So topical would be eye drops and systemic would be IV or oral. And we'll come back to what those specifically are. Topical steroids. Now, I would say topical steroids are treatment options for a lot of ophthalmological, gosh, that's hard to say, conditions, but I've only ever seen them been used very rarely and by specialist ophthalmologists. This isn't something you're going to be prescribing for people in A&E. They have a lot of risks and a lot of side effects with them. So you wouldn't really be expected to prescribe them in F1, but just know that they're a potential option for treatment. And then if all of that hasn't worked, we're going to go for a surgical option, which is a peripheral iridotomy. And you can see on this photo where the arrow is pointing to, that is the iridotomy. So that's a laser hole that's cut through the iris to allow the aqueous to drain out through another route that isn't that angle that's closed off. So something I really struggled to get my head around when I was revising for finals was different types of eye drops. They all seem to have really complicated names and I couldn't remember which one does which. So I just thought I'd make this table just to help you guys revise as well. So you've got your dilating eye drops. So tropicamide, that's an antimuscarinic, blocks the action of the PNS, and so it dilates the pupil. So the dilating ones either block the PNS or activate the SNS. Okay, so tropicamide blocks PNS because it's an antimuscarinic. Cyclopentolate also blocks the PNS. It's an anticholinergic, so it again dilates. Phenylephrine is alpha adrenergic receptor agonist, and that activates the SNS. So they're sort of your dilating ones, and you might use those when you're examining patients to get a better look with fundoscopy in the back of the eye. So that was why cyclopentolate is not a treatment option for acute angle closure glaucoma, because if you dilate the eye, you're just going to close off that angle more and it's actually going to make symptoms worse. And using these eye drops can potentially precipitate acute angle closure glaucoma as well. Eye drops that reduce the intraocular pressure. Timolol, like all things that end in lol, it's a beta blocker that just reduces the aqueous production. Latanoprost is a prostaglandin analog, and that increases that aqueous flow out of the eye. And pilocarpine activates PNS, therefore constricting the pupil and allowing more aqueous flow out of the anterior chamber. Other things that reduce intraocular pressure is acetazolamide, which you'll probably have heard of. That can either be used topically as an eye drop, or you can use it systemically, IV or orally. Other eye drops just to be aware of, fluorescein, that stains the eye yellow, and then you can look under a slit lamp to see if there's any ulcers or abrasions. Tetracaine is an anesthetic that's used prior to surgery. You can also get antimicrobials, so sort of antibiotic eye drops like chloramphenicol, steroids, which we already touched on, and then artificial tears, which can be used for symptomatic relief in things like blepharitis or are even used towards the end of life as well. Okay, so moving on to question number 2. So this is a 23-year-old male. He's got a sudden onset redness just in one eye. He's complaining of flashes and floaters. He's got a reduced visual acuity and there's pain on eye movements. he also is complaining of regular morning back pain that takes over 30 minutes to ease after he's woken up. So, given the most likely conditions, which one of these signs would you expect to find on examination? Okay, I'll end the poll there. So most of you have gone for C, but you're all a little bit split between these. So can anybody tell me what condition we're hinting at here? Anterior uveitis, correct. Yeah, absolutely. And what's the morning back pain got to do with it that takes 30 minutes to ease after he's woken up? Yeah, HLA-B27, ankylosing spondylitis, correct. So ankylosing spondylitis has a link with anterior uveitis. Perfect. So just looking at these signs that you'd expect to find on examination. Sorry, I should have moved on and shown you that you were correct. It was C. It was a hypopyon on slit lamp examination. So a swollen optic disc on fundoscopy. So that is a sign of raised intracranial pressure, so like trauma or idiopathic intracranial hypertension. A fixed and dilated pupil on the left side, we already discussed, was a sign of acute angle closure glaucoma. Hypopyon on slit lamp exam, that is a sign of anterior uveitis, that's correct. Cranial nerve 3 palsy, how would that present? Down and out. You guys are smashing it, well done. Yep, so a down and out appearance of the eye with a dilated pupil if there's full involvement of all of the nerves, and we'll come back to that. And then pustular discharge on the eyelid, that would be more indicative of bacterial infection, for example, conjunctivitis or keratitis. So here's a yucky picture. There are good clinical signs to remember that are indicative of anterior uveitis. So there's the hypopyon, and I'm not sure if I can maybe convince you that there's a fluid level just at the bottom of the iris. There's a white fluid level, and what that is that's a collection of white blood cells in the anterior chamber. So it's a fluid collection that's building up, and then you can see that on slit lamp. I'm sorry, there should be a space there. That's supposed to say posterior, and I never know how to say this, synechiae. I don't know how to say it, but essentially these are adhesions that pull the iris into abnormal shapes. So you can see that the iris isn't fully round. And then ciliary flush, this is just the red appearance, and it spreads from the cornea outwards to the rest of the eye. Okay. And as we said, anterior uveitis has an association with the HLA-B27 gene. So one of those conditions is ankylosing spondylitis, which was what this patient suffered from, typically seen in young men, early morning back pain, back stiffness. But there's also an association of HLA-B27 with IBD. These are all associations when anterior uveitis presents acutely. You can also get chronic anterior uveitis that are associated with other conditions such as sarcoid, syphilis, and TB. Okay, so a good piece of advice from the NICE guidelines to remember is that anyone with a potentially sight-threatening cause of a red eye should be referred for a same-day assessment by an ophthalmologist. And anterior uveitis is one of these potentially sight-threatening causes. So the management of it is with steroids. These can be oral, topical, or IV, but remember that we said we're not going to give topical steroids on the eye without ophthalmology advice. And realistically, you're going to be sending these straight to the eye hospital, potentially with oral steroids, but potentially without any treatment. So you'd also want to be giving cycloplegic mydriatic medications. Now that sounds really fancy, but essentially cycloplegic means it paralyzes the ciliary muscles, and mydriatic means it dilates the pupils. So what these medications do is they reduce pain because they're stopping the ciliary muscles spasming, which is what is causing that acute severe pain in anterior uveitis. You might want to give immunosuppressants. So these are like DMARDs or TNF alpha blockers. And there's other options like laser therapy, cryotherapy, or vitrectomy in severe cases that aren't responding to these other treatments. For a lot of these ophthalmological conditions that are going to be seen acutely by an ophthalmologist, you don't need to know the specifics of the treatment. You just need to know the general idea and the sort of pathway of treatment that they're going to undergo. So potentially sight-threatening causes of a red eye. So these are ones that you need to remember need a same-day assessment by an ophthalmologist. Acute angle closure glaucoma, trauma, FB, a foreign body in the eye, a corneal ulcer, endophthalmitis, which is common after cataract surgery, neonatal conjunctivitis, anterior uveitis, and scleritis. And just to note, those bottom two, the anterior uveitis and scleritis, they don't necessarily need to be a same-day referral to ophthalmology. They just need to be seen within 24 hours, if that makes sense. So, you know, if it's at 8 p.m, you just need to make sure they're seen the next day by an ophthalmologist. Question number 3. So this is a 6-year-old boy. He's got swelling around his right eye. He's got painful eye movements and a reduced visual acuity. Given his most likely diagnosis, what is the most appropriate imaging? Okay, so we seem to be a little bit split between B and C. Most people are going for B, but some people are going for C. So the correct answer is CT, orbit, brain, and sinuses. What do we think the diagnosis is in this case? Yeah, orbital cellulitis, correct. Brilliant, guys, well done. So what we are worried about are the red flag signs in orbital cellulitis. So you only image when you have these red flag signs. And so, sorry, you only image when you've got these red flag signs. They're not improving after 2 days of antibiotic treatment, or for some reason you can't examine the eye. So that might be it's so swollen that you literally can't see whether their pupil's reactive or not. What these red flag signs indicate, or non-improvements indicates, is that there are complications involved in the orbital cellulitis, or that the infection has progressed into other parts of the brain, or that the infection is really, really severe. So actually, usually if we're pretty certain of a diagnosis of orbital cellulitis and it's not complicated and it's responding to treatment and there's none of these red flag signs that you can see, we don't need to image. We can just treat them empirically without imaging. But it's highly likely that if someone presents with orbital cellulitis, they're going to have one of these red flag signs and we're going to need to image them. So the red flag signs are painful eye movements, reduced visual acuity and or visual fields, proptosis, that's sort of pushing forward of the eye. And the reason that's a red flag sign is because you've got all of that pus and inflammatory exudate building up behind the eye, pushing it forward. Relevant. It's not a relevant afferent pupillary defect. Sorry, it's a, oh my gosh.
Relative.
Thank you. I'm really getting my words mixed up tonight. Thanks, Katie. Relative afferent pupillary defect, otherwise known as a Marcus gun pupil. So that's when the pupil constricts more when light is shone into the other eye. So when light shone into the affected eye, it doesn't react. but when it's drawn into the other eye, the reflex, the concentric reflex is still intact, but the direct reflex isn't. Chemosis, which is swelling of the conjunctiva, which is in that lovely photo in the bottom right, and altered coloured vision. Complications of orbital cellulitis, can anyone name me any? Permanent vision loss, very good. Encephalitis, yeah, it's more likely to be meningitis because it will spread and irritate the meninges first. But I guess if it gets really severe, it could pass through and then cause inflammation of the brain as well. Yeah. Other things that we'd be worried about would be an abscess formation and a cavernous sinus thrombosis. We'd be worried about a cavernous sinus thrombosis if you've got bilateral eye signs, okay? And I think one of the options, sorry, just one sec. Yeah, so one of the options was an MR venogram. Now you can use that to diagnose a cavernous sinus thrombosis. And so you'd be worried if you've got bilateral eye signs. So how does a cavernous sinus thrombosis present? So you might get a headache and you'd be getting bilateral vision disturbance. But in this context, you'd be thinking, okay, you start off with an orbital cellulitis and then you could also present this. Similar stroke mimicking symptoms. All right. So orbital cellulitis is usually preceded by an upper respiratory tract infection. This then spreads through the ethmoid sinuses in the nose. And how are we going to treat someone with orbital cellulitis? Yeah, IV antibiotics. If they're septic, we're obviously going to do a sepsis 6 as well. If they end up having an abscess, we're going to drain it. So going back to the questions, obviously this boy has red flag signs. He's got painful eye movements and reduced visual acuity. So we know that we need to image him. Fundoscopy isn't going to tell us a great deal because the aim of imaging is just to try and find out whether the infection has spread or whether complications have occurred. MR venogram would be useful if we're looking for a cavernous sinus thrombosis, but he hasn't got bilateral eye signs. There's no headache. And so we're just left between the MRI or the CT, orbit, brain and sinuses. MRIs are really good at looking at soft tissues, inflammation, things like that. But CTs are quick, essentially. So in an emergency situation, if you're trying to find out about emergency complications, CT is always the imaging of choice. You could do an MRI, but it might take you 2 or 3 days for that patient to even get the MRI, whereas in the emergency department, they can probably get one within an hour. So that's why we're choosing CT. Okay. So this question is about a 32-year-old gentleman who has a gritty sensation in his eye. He's got watery discharge, he usually wears contact lenses, slit lamp with fluorescein dye is applied. And what does this image show? Okay, I'll end the poll there. Most of you going for B, herpes simplex virus. Oh, sorry, I didn't actually show you the right one there. You were correct. It was herpes simplex virus. Sorry, it was B, herpes simplex virus. Okay, so this is a question about keratitis. So looking at the risk factors of keratitis, essentially that depends on infection. So for bacterial or fungal, anything that disrupts the corneal epithelium, so for example trauma or contact lens wear, that's going to increase your risk of bacterial keratitis. And what you should ask all contact lens wearers about is if they sleep, swim or shower in their contact lenses. For viral keratitis, you'd be wanting to ask about direct contact with infected HSV secretions, so herpes simplex virus secretions. If they've had any kind of facial trauma or if they're immunosuppressed, because these can all reactivate inactive herpes simplex virus that's remained dormant. The way you determine whether it's sort of bacterial or viral keratitis is based on the sort of discharge. And in this question, although this bloke was a contact lens wearer, so he has risk factors for bacterial keratitis, he actually has a watery discharge, which is more characteristic of a viral keratitis. People may also have a history of cold sores, which would be another presentation of the herpes simplex virus as well. The symptoms that you'd get would be a painful red eye with discharge and reduced visual acuity. The signs, so this is where the slit lamp comes in. You could potentially examine with a slit lamp with fluorescein, and then you'll be able to see the epithelial defect. So the herpes simplex virus classically causes a dendritic ulcer, which is what was shown on that previous fundoscopy image, that spidery sort of pattern. Whereas anything where there was like a corneal abrasion would present in either a straight line or a very well-defined rounded lesion compared to this sort of spiry dendritic ulcer. Keratitis is a clinical diagnosis. You don't need any investigations to be able to confirm it. It's just purely on history taking an examination. But if you did want to confirm the diagnosis, if it was a very treatment-resistant infection or it was very severe, you could do swabs as well. You can, obviously, if they're a contact lens wearer, get them to stop wearing contact lens just whilst you're treating the infection. It's only going to make it worse and increase the abrasion and infection. You might want to give antibiotics if you've got bacterial keratitis, and if it's very severe and doesn't seem to be going by itself. Herpes simplex virus, so viral keratitis, it will go by itself. You don't need any treatment. But if it's a recurrent disease or it's very severe, you might want to consider antivirals. And often when people get one dendritic ulcer, they're prone to getting more. So you might want to consider long-term prophylaxis with antivirals. Sometimes you can use steroids, again, under supervision of ophthalmology. And as a last resort, you can do surgery if it's very complicated or it's not responding to treatment. All right. So just to clarify, question 4, it was herpes simplex virus was the answer. All right, that was B. Okay, so moving on to question 5. It's about a 24-year-old female. She's been diagnosed with bacterial conjunctivitis. She only had 3 days of symptoms, usually fit and well, never had it before. What's the most appropriate management option? Oh. Okay, I'm going to end the poll there. Most of you have gone for A. So it's actually D. No medication is required at this stage. So just running through the options, chloramphenicol eye drops would be used to treat bacterial infections of the eye, but we'll come back to why this lady doesn't need them in a little bit. Steroid eye drops, we've spoken about a lot. Cetirizine tablets, they're antihistamines. They might be used for an allergic conjunctivitis prevention. And acetazolamide, we mentioned earlier, would be used to treat acute angle closure glaucoma. So this question is about conjunctivitis. Again, the risk factors depend on the type. You can have viral, bacterial, or allergic conjunctivitis. In viral and bacterial, obviously, you're more at risk if you come into contact with someone who's got conjunctivitis and then they're in contact with you and you spread it to your own eyes. You want to also consider for bacterial conjunctivitis, sexually transmitted infections as well, like gonorrhea and chlamydia. Allergic conjunctivitis, if you've got a history of atopy, you're going to be more at risk. Present with a red eye and discharge. And if you're looking for any signs on examination, typically in an allergic conjunctivitis, you can see a cobblestone appearance. So that's just kind of swelling on the eyelid. It looks a little bit lumpy and like a cobblestone, essentially. Both viral and allergic conjunctivitis tend to present bilaterally. Bacterial can be bilaterally, but it's usually unilateral. And you can tell the difference between them depending on the type of discharge. So as already said before, you know, a bacterial infection is more likely to be a purulent. And particularly gonorrhea gives a lot of purulent discharge as well. Whereas allergic and viral conjunctivitis would be watery, and allergic would be particularly itchy as well. Again, conjunctivitis is a clinical diagnosis based on the history, the signs and symptoms and the examination, but you can again do swabs if it's very severe or treatment resistant cases, or if you've got an immunosuppressed person who you think might have an atypical infection, that might be a good idea to do a swab. If you did do a swab, just one thing to note is that in an allergic conjunctivitis, you're going to see eosinophils, okay? So you won't necessarily see active infection, but you'll see a predominance of eosinophils. In terms of management, often you don't need to give any sorts of treatment. It will often self-resolve within a few days, but you'd consider treatment if you've got a recurrent case, so they've had multiple of these infections, or if it's not going within 7 days. Okay, so this lady only had symptoms for 3 days and she's never had conjunctivitis before, so you're not going to need to give her any treatment. And the antibiotic eye drops obviously would usually give chloramphenicol, which is why you all chose chloramphenicol. You might need to give systemic antibiotics if you do a swab or you suspect gonorrhea or chlamydia, because you obviously want to treat the underlying infection as well. For viral, you're going to promote hygiene, so don't share towels, don't wash your face using the same flannels, wash your hands a lot, things like that. And then for allergics, you might want to give antihistamine tablets, and you can also give topical mast cell stabilizers that helps, so eye drops that help with allergic conjunctivitis. And one of those that might be good to remember is sodium chromoglycate. Okay, just check where we are with the chat. Yeah, so give chloramphenicol if you've got a recurrent case, so people are, you know, having multiple bacterial conjunctivitis infections, like, so you're having them and they are going, but then they're coming back, or if it's not going after 7 days of symptoms. Okay, so if it's not disappeared within 7 days, you would consider antibiotic eye drops at that point. Okay, number 6, a 44-year-old male presents with bilaterally painful eyes, pain on eye movements, red eyes, he's watery eyes, and he's got reduced visual acuity. So which of these in his past medical history would be most likely to be present if he has a diagnosis of scleritis? Great, so most of you have gone for A, and that is correct. So scleritis is inflammation of the full thickness of the sclera, whereas episcleritis is very similar, but it's just the surface of the sclera and it's not as serious. The way you differentiate between scleritis and episcleritis is the severity of pain. Scleritis is really painful, and you don't get visual loss or blurred vision with episcleritis. You can also look through a slit lamp and you would see lots of changes on scleritis. So things like the sclera thinning, and nodules and sort of corneal changes that you wouldn't see any of those in episcleritis. Scleritis is associated with a multitude of conditions. So these include rheumatoid arthritis, lupus, IBD, sarcoid, or granulomatosis with polyangiitis. In about 50% of people presenting with scleritis, they've got an associated systemic condition. So it's really common for them to be linked. The symptoms can be bilateral. It's not uncommon for them to be bilateral. It's about 50% of the time they present bilaterally. So they got red eyes, watering, pain, reduced visual acuity alongside photophobia, and they may have abnormal pupil reactions because the inflammation and the fixing of the vessels around the sclera because of the damage and the inflammation that's occurring leads to non-reactive pupils. Basically, everything's just tightened up with inflammation and damage, so it doesn't react. So the management is, as we've said before, all sight-threatening conditions need to be seen the same day by ophthalmology. So definitely need to get them to an ophthalmologist. And then treatment options include NSAIDs, steroids. They can obviously be topical or systemic. Antibiotics, again, can be topical or systemic. And overall, you want to treat the underlying condition. So better control of the associated condition is going to lead to fewer flares of the scleritis. So question 7, 57-year-old female presents with sudden painless loss of vision. What does fundoscopy show? Okay, great. Most of you have gone for D, which is occlusion of the central retinal artery. Great. So what signs can we see on this fundoscopy? Lovely cherry. Pale retina and cherry red spot, absolutely. So they're sort of the not eponymous, but the signs that you find only with central retinal artery occlusion. So the cherry red spot is this bright red spot that's surrounded by a sort of ring of paleness. The cherry red spot is because the macula is thinner than the rest of the retina, and because the retina is then quite pale behind it, you can then see through to the underlying choroid layer at that point. And the reason that retina is pale is because of a lack of perfusion. Because you've occluded one of the arteries, it's not getting as much blood supply, becomes quite pale, and then you see the choroid underneath, which is why you get the changes that you see on fundoscopy. So we've now moved on to the section of our talk where we're looking at acute painless loss of vision. So it's all of these conditions shown in the box. So central retinal artery occlusion, it can be sort of by two different methods, really. So it could have a thrombus or embolism in the same way that you would have an MI or a stroke. So in that sense, if it's by that mechanism, all of the risk factors are the same as for atherosclerosis. So, you know, like hypertension, increasing age, smoking, things like that. But you can also get central retinal artery occlusion if you've got giant cell arteritis, so vasculitis that then affects either the ophthalmic or the central retinal artery itself. And risk factors for GCA would be females, increasing age, and Caucasians. The symptoms of it is a painless loss of vision, and often there may be amaurosis fugax. Oh, I say often, it actually occurs in less than 10% of patients, amaurosis fugax. So it's a sign that we're told to look out for, but it only happens in a few people. What is amaurosis fugax? Yeah, so David, you've got that correct there. So it's kind of like a TIA occlusion of a retinal artery. It's the TIA equivalent of a central retinal artery occlusion, if that makes sense. So it's a transient, the same signs and symptoms, but very transiently, as you've got the occlusion that lodges itself enough to cause symptoms, but then passes on for some reason. So it's transient loss of vision for a few seconds or minutes. The signs that you're going to get are RAPD, reduced VA, and a cherry red spot, and the pale retina on fundoscopy. And the investigation, so you're trying to find the underlying cause of why there's been an embolism. Obviously, you'll take a history, you'll look for risk factors, see if there's any other signs of symptoms of GCA, and then you'll use that to direct your investigations. So if you're looking for a thromboembolic cause, you'll be doing things like an ECG, a carotid duplex to see if you can see any thrombuses, an echo, bloods. Basically, you're trying to find the underlying pathology that might have caused that thromboembolism. And if you're looking for GCA, you want to be doing bloods like CRP and ESR. Okay, so the management, if it's caused by GCA, you're going to treat it like GCA. So what would be the treatment of GCA? Yeah, high dose steroids, brilliant. But otherwise, all of the rest of the treatment for central retinal artery occlusion is really anecdotal. There's no evidence for it at all. But what the textbooks say that we've got to do is an ocular massage. So essentially just rubbing on the eye to try and dislodge that clot. Increasing the oxygen content. So you could use hyperbaric oxygen, carbogen, and these dilate the retinal arteries and try and hopefully help that clot pass through. Reducing the intraocular pressure with acetazolamide might help increase the perfusion of the retinal arteries. Or fibrinolysis. So if the patient presents within 24 hours of symptom onset, you can use fibrinolysis in the same way that you would use it for a stroke. So you'd use something like urokinase, alteplase, things like that. All right, and then you're going to do long-term management via risk factors. Obviously, that only counts for atherosclerosis and the thromboembolic causes, because you can't really manage the risk factors of GCA in the same way. You just treat with long-term steroids. So question 8. 55-year-old female has retinal detachment. Which of these is a risk factor for retinal detachment? Okay, great. So most of you have gone for D, a history of diabetic retinopathy, and you are correct. So yes, we'll come back to why each of those are wrong, sorry. So retinal detachment, the risk factors for them are being male, an increasing age, so myopia, short-sightedness, because you've then got a bigger retina, there's more to potentially detach from the choroid layer underneath, a family history or even a personal history of retinal detachment, previous surgery, and trauma. Retinal detachment can be either tractional, which means sort of pulling of the retina up from the choroid layer, or exudative. So the underlying disease leads to fluid buildup behind the retina, and that pushes that retina off. Tractional retinal detachment is common in diabetes, and that's it. The mechanism of that is when the vitreous pulls on the retina, which pulls it off the choroid, and so that is why the answer was diabetes is a risk factor for retinal detachment. Does anyone know a specific sign that we might see on slit lamp examination for retinal detachment? It's a bit of a tricky one. No. Okay. So it's called the tobacco dust appearance. And what you see in the anterior vitreous, as the retina is peeled off the choroid, the pigment cells that have become damaged and released, that are usually sealed in between those two layers, start floating around, and you can actually see them in the vitreous as they've come up from the choroid through that tear in the retina. So tobacco dust appearance. So symptoms of retinal detachment: you get a curtain across your vision as the retina peels up and starts to progressively peel away. That's why your vision becomes increasingly lost across the field of vision. You might get blurred vision, flashes and floaters, and it's often painless. So I saw in the Q&A there was a question about posterior vitreous detachment compared to retinal detachment. Posterior vitreous detachment often precedes retinal detachment, because as the vitreous starts to detach, it drags with it the retina. And posterior vitreous detachment typically presents with flashes and floaters, maybe a slightly blurred vision, but you wouldn't get the sort of complete loss of vision, the curtain across the vision that you get with the retinal detachment, because you're not actually losing those pigment cells and things that are allowing you to see. So signs that you're going to see in retinal detachment are reduced VA, RAPD, the altered red reflex, and obviously a visual field defect as that retina has been pulled away. On investigation, you're going to see the tobacco dust sign in slit lamp examination. On fundoscopy, you might be able to visualize the location and the number of different tears that you're going to see on the retina. And you might even be able to see any underlying fluid that's bulging up behind the retina. You can do an ocular ultrasound, which can actually visualize that fluid buildup under the retina as well. And in one thing that might cause this fluid buildup, sorry, I know I've been talking a lot about this exudative cause, but not actually saying what's causing it, is that the retinal vessels can tear and start to bleed, and they bleed in between the retinal and the choroid layers, which pushes away the retina off the choroid layer. So a tear of a retinal vessel might be visualized as well by the ultrasound. So if you suspect a person's got posterior vitreous detachment, they've got the flashes and the floaters, what you'd want to do is have a look in their eye, and if you can see any small retinal tears that might develop into big retinal detachment, you want to treat it with laser photocoagulation. If you manage to treat posterior vitreous detachment well, most of them don't go on to full retinal detachment. But if it does progress into retinal detachment with visual loss, you want to do some form of surgery. Now, there's 3 types of surgery you can do. You don't need to fully know the details, but I think knowing the rough options is a good idea. So vitrectomy, that's when the gel of the vitreous, it all gets drained. So the retina then sits back against the choroid, and the inside of the eye is just pumped full with liquid or gas to push that retina back against the underlying layer. Pneumatic retinopexy is when the same sort of thing, where you're injecting gas or liquid, but you're injecting it into the vitreous, and then that pushes the retina against the underlying layer, and then you seal that in with cryo or laser therapy just to keep it in place. A scleral buckle, it's rare now, but essentially a band is applied around the whole eyeball. It sounds pretty gross to me, but essentially you bend the retina in such a way that it self-seals and there's actually no hole left in between the bits of the retina. Okay, question 9. A 19-year-old female presents with blurred vision, which started suddenly 3 days ago. Her colour vision has also been affected, and she's had these strange episodes of numbness and tingling on various locations of her body. Given the most likely diagnosis, what is the most appropriate management option? Great. So most of you are going for A, high dose steroids. Correct. So what do we think the underlying diagnosis is for this lady? MS, correct. Yeah, MS. And what specifically is she presenting with on this occasion? Optic neuritis, correct. So optic neuritis symptoms are usually unilateral. So a unilateral loss of vision, eye pain, and characteristically reduced colour vision. So that tends to be like the loss of the colour red. The risk factors for optic neuritis are the same as for MS. So can anyone tell me a risk factor for MS? Being female, correct, yeah. Lack of vitamin D, yeah. Yeah, so essentially it's about a higher latitude, and I think that's towards with the lack of vitamin D. Usually presents between 20 and 50 years of age. So you're finding these in fairly young females. You also present with photopsias. So photopsias are flashes that are precipitated by eye movement. So they're not the same as flashes and floaters. They're when you move your eye, you get flashes. The signs would be a reduced visual acuity, RAPD, and papilloedema. Papilloedema may or may not be present, but it's characteristically something that you'd say you'd look for on fundoscopy. Okay. The reduction in visual acuity tends to happen in hours to days. So it's quite an acute onset, but then within 2 weeks, it will start to improve. So it will be quite self-limiting. You might want to investigate using an MRI or LP. If you know the patient's got MS, you don't need to investigate. This is a classical presentation of an MS flare. But if you were suspecting MS, you'd do an MRI, brain and spinal cord, and you'd be looking for lesions that are disseminated in both time and place. If MRI has not been successful in diagnosing MS, but you're pretty certain, you might want to perform a lumbar puncture as well. Optic neuritis doesn't necessarily need treatment, as it will self-resolve within 2 weeks. But if a patient has known MS, is in severe pain, or has a huge reduction in visual acuity, you want to give them IV steroids. Okay, and that will probably be something like methylprednisolone. Give them high dose steroids and then taper down on oral steroids when they're starting to improve. And then this is an MRI of somebody with optic neuritis. So I don't know if you can see, so as we are looking at it, forget which way around the patient is, as we are looking at it, the eye on the right, I don't know if I can convince you, as you look down the optic nerves, so the stringy bits connecting the eyeball to the brain, there's a whitening on the right side, and that's the inflammation that's seen with optic neuritis, the inflammation of the optic nerve. So that shows us bright white just surrounding the optic nerve. Question 10. 56-year-old man has diabetes and they look in the back of his eye on his annual eye check. How would you describe this? Okay. We seem to be a bit torn between C and D, so whether it's pre-proliferative or proliferative retinopathy. The answer is pre-proliferative retinopathy. So we're now moving on to the chronic painless loss of vision section of the talk. So these are all the conditions we're going to be covering. So if I show you these 3 fundoscopy images, and I hope they're projecting well onto your screens, they show the different stages of diabetic retinopathy. So the one on the left is background retinopathy. Then we've got pre-proliferative in the middle, which is the image that we've been looking at. And then we've got proliferative retinopathy. So to have background diabetic retinopathy, you've got to have at least one microaneurysm. Now, the microaneurysms are sort of little outpouchings on the vessel walls. Basically, there's weakened capillaries, and so just they start to bulge a little bit. It's quite difficult to see, but you can maybe convince yourself, if you know that someone's got diabetes, that the width of the vessels on the retina aren't consistent and tapering off. They could be a little bit bulgy in places, if that makes sense, and they're the microaneurysms. Then we go to pre-proliferative. So you're going to have microaneurysms. You're then going to have the dot and blot hemorrhages that we can see. They're like the smears of blood that are on the retina, and these are from damaged vessels that rupture and leak blood. Then you've got your hard exudates, which are deposits of lipids that have leaked out through these damaged blood vessels and deposited themselves onto the retina, and the cotton wool spots, which are mini infarcts of the retinal nerve fiber layer because it's chronically ischemic. And then when we get to proliferative, the clue's in the name, you're going to get loads of neovascularization. So obviously what we can see on this one is we've got, when we're looking at the proliferative diabetic retinopathy on the right, we can see that we've got sort of hard exudates, cotton wool spots. We can see some of those microaneurysms, but what we've also got is a lot of new vessels forming, and that's how you tell the difference between proliferative and pre-proliferative. I hope that I can convince you that actually the number of vessels isn't significantly different between the background and the pre-proliferative diabetic retinopathy images that you can see, but that it very significantly changes when it gets to proliferative retinopathy. Someone's asked, is the proliferative retinopathy always that bad? No, obviously I've done this as an example to try and show you the most extreme and obvious sections that you will see. If you're asked to look at fundoscopic images in exams, I'm sure it will be really obvious which category it sits into. They're not trying to cheat you out of the marks. They will make it quite obvious. I think if you were actually examining a diabetic person's eye, in reality, it's going to be quite difficult to tell between the pre-proliferative and the proliferative stages. But just so you know what you're actually looking for.
Holly, sorry to interrupt. Do you mind just pointing out the cotton wool spots and the exudates again on those photos? Someone's just in the Q&A.
Yeah, so the hard exudates, if you look in the middle images, Casey, can you see my mouse?
I can, yeah.
Yeah, okay. So the hard exudates are these big, well-defined lumps. All right. And then the cotton wool spots are kind of these fluffy. They look fluffy, whereas the hard exudates have like a very solid outline, if that makes sense. So it's probably not a very good way of thinking it, but you're literally thinking like you're depositing hard fats here, and here it's fluffy because it's an area of ischemia. So it's not going to have solidified edges. Okay, so the complications of diabetic retinopathy, and the reason why we care is because it can lead to lots of bad things. So we've already talked about its link with retinal detachment. It can also lead to vitreous hemorrhage, rebiosis iridis. So essentially that just means new vessel formation in the eye. It's just a posh way of saying that. Optic neuropathy, so damage to the optic nerve because of reduced blood supply and ischemia to the optic nerve, and it also has an association with cataracts. So what we want to do is manage it via laser photocoagulation, which is what I've shown here on the right. Essentially, you get a laser and you just blast it at all of these areas of neovascularization. And actually, I think it was Chloe was asking, is the proliferation always this bad? This is a good example of where you can see some proliferation here that is abnormal and you wouldn't expect, but it's not quite as extreme as on the previous image that we looked at. So we're using the lasers to destroy that new vessel formation. We can also use anti-VEGF medications, so anti-vascular endothelial growth factor medications. You inject them directly into the eye and that reduces the growth of new vessels. And as a last resort, you can do sort of keyhole surgery on the eye, which is called vitreoretinal surgery. Question 11. 82-year-old gentleman has gradually worsening eyesight. He's struggling to read and he thinks he's losing the center of his visual field. Which of these features would prompt an urgent ophthalmology referral? And yeah, Chloe, you're absolutely right. The vessels the new ones look small and spidery. The big, fat, chunky vessels are the ones that are consistently there. But yeah, neovascularization has small, spidery vessels. It's a good way of putting it. Great. So most of you have gone for C. And that is correct. So all patients, oh, sorry, I should probably say what diagnosis do we think this is? Yeah, AMD or ARMD, however you want to abbreviate it, age-related macular degeneration. And you're absolutely right. What we're getting at is the difference between dry age-related macular degeneration and wet age-related macular degeneration. So everyone with age-related macular degeneration is going to be referred to ophthalmology anyway, in case it converts to wet age-related macular degeneration. But we would want an urgent ophthalmology referral if there's signs of wet AMD. And one of those signs is rapidly increasing visual loss. The rest of them, drusen, you'd expect to find in dry AMD. Eyesight continuing to worsen is typical in dry AMD. Reduced visual acuity, again, also a sign of dry AMD, and both eyes being affected is also typical, but rapidly increasing visual loss is a sign of wet AMD. So the biggest risk factor is increasing age, and it presents particularly in people over 60 with progressive central visual loss exacerbated by low light. But any rapidly progressing loss of vision, as we said, is a sign of wet AMD, and you need to worry a little bit more. Signs that you might see is central scotoma. So that's just a posh way of saying a loss of the center of the vision. Metamorphopsia, can anyone tell me what that is? Straight lines appearing curvy, yeah. So what you do is you look on an Amsler grid that to normal people looks just like straight lines, but in people with AMD will start to look curvy, particularly in the center of the grid, in the center of the vision, they start to become wavy. Drusen are sort of normal deposits of lipid and protein. They're normal as we age, but they increase in number in AMD, and that's what starts to distort our vision when they're like particularly big or particularly numerous. Geographic atrophy, that essentially just means atrophy, particularly around the macula, and neovascularization, which you'd see in wet AMD. So imaging is gold standard. That's a bit of a vague term, sorry, but in terms of diagnosis, you need to image them for it to be gold standard. So you're going to do probably OCT, which is ocular coherence tomography. That essentially looks at like a cross section of the retina, and you can see all of these signs like the drusen, the geographic atrophy, things like that, just through a cross section of the retina. Management, there's no cure. What you want to do is you want to manage risk factors, but to be honest, the only risk factor we know is increasing age, so you can't really do that. A study was done called the AREDS2 study, and what they found was nutritional supplementation can help in these patients. So that contains things like zinc, vitamins, and other minerals. What you want to do is consider more holistic treatments, things like registering as blind, social service input, psychological involvement, occupational therapy involvement. But if you think they're progressing to wet AMD, so they're getting rapidly increasing loss of vision, he wants to do an urgent ophthalmology assessment, and you're going to give them anti-VEGF injections in the same way that you treat diabetic retinopathy to stop that neovascularization. So a 65-year-old female presents with worsening of her vision. Which of these would point towards cataracts? Okay. So we're a bit torn between halos and starbursts. So it's starbursts. Essentially, this is, as I was saying before, just learning the signs of different ophthalmological conditions. We've talked about loss of central vision is AMD, the halos is acute angle closure glaucoma, the straight lines looking wavy, again, is AMD, and the floaters you can find in posterior vitreous attachment, retinal detachment, and also acute angle closure glaucoma. So in terms of what we actually mean by those, is on the left, these are the halos that you'd see in acute angle closure glaucoma, so essentially rings around the light, whereas someone with cataracts would have starbursts, which is what's seen on the right. So sort of instead of the ring, it's coming out in like spikes, just to give you an idea of what the patient might be trying to describe, because I don't think they'll come in saying, I see starbursts in the headlights, doctor. They'll probably be like, the headlights look really blurry and pointy. And that's, you know, sort of looking at those descriptions, you might be able to differentiate. So cataracts, the risk factors, we've covered the fact that diabetes is related to them. Topical steroids can cause cataracts, which is why I said you should only really use them under ophthalmology supervision. Increasing age, and then cataracts can also be congenital. These are the ones that are present from birth. They're associated with congenital rubella syndrome and are often diagnosed in the newborn exam because of a lack of red reflex. You often need surgery pretty early on in life to prevent amblyopia. You can get different types of cataracts depending on which part of the lens is affected, but I'm sure you've read up about those and can have a look at the different appearances. Symptoms are progressive blurring of vision, starbursts around light, and colours looking dull. And you might see a clouded lens and a reduced red reflex on examination. Essentially, with management, you want to hold off surgery until absolutely necessary. So you do lifestyle management factors, control the diabetes, stop smoking, don't use steroids, things like that. And then when the cataracts are starting to affect the quality of life, because no surgery is without risks, so you don't really want to do it unnecessarily. When it is starting to affect their quality of life, you perform phacoemulsification and a lens implant. So phacoemulsification is when you get ultrasonic beams, break down the lens, and then you use a small hoover, vacuum up the lens, and then put in another lens. The specific complications of this surgery, we talked a little bit about it earlier, is endophthalmitis. So essentially that's an infection in the aqueous and also potentially the vitreous humour. It's rare, but it's very severe, so you don't really want that. And then you can also get sort of a pacification at the back of the lens, which presents very similarly to cataracts itself, but all you'd need to do is just drill a laser hole through that to allow some light to get through the opaque bit. So posterior lens opacification and endophthalmitis, they're the risks of cataract surgery. Okay, 70-year-old lady has cataracts. She only drives her own car, not a lorry, bus or taxi. Which of these is true regarding her ability to drive legally? Okay. Seem torn. Okay, I'm going to end the poll. You're fighting it out between D and E. So the correct answer is E, she needs a visual acuity of at least 6/12 with glasses. So this is a bit of a boring slide, but I thought it would be useful for your guys' revision. It's good to know the driving regulations, and it's also really crucial in an ophthalmology history to ask about whether they drive. So these regulations are with the use of visual aids. So if they usually wear glasses, put them on to test their vision. And it's the same regardless of whether they can see out of one or both of the eyes. So you need to be able to read a number plate from 20 meters away, have a visual acuity of at least 6/12. So that's if they can only see out of one eye and they're only driving their own car, they just need to be able to see 6/12. For lorry or bus drivers, that's slightly different. Those measurements are slightly different. So in their best eye, they need 6/7.5 and at least 6/6 in the other eye. And they need an adequate visual field, obviously, because you need to be able to see in your peripheral eyesight. So visual fields need to have formal assessments for lorry, bus, taxi drivers. But for people who just drive their own car, it doesn't need to be formally assessed, but it'd be something you consider. For example, if they're recovering from a stroke and they've had a visual field impacted, that would be something that would need to be considered when disclosing to the DVLA. Okay. 14. 42-year-old female is diagnosed with retinitis pigmentosa. Which of these is true? These last few questions are just pretty quick and fact-based, but I thought we should probably cover them in a talk about ophthalmology. Okay, so most of you have gone for E. So, and you would be correct. Night blindness is a typical symptom. So in retinitis pigmentosa, peripheral vision is lost before central vision. Everyone has to inform the DVLA about their diagnosis. We'll talk about what fundoscopy demonstrates, and drugs, for example, something like chloroquine, can lead to presentations that are similar to retinitis pigmentosa. So for example, night blindness, but it's not actually retinitis pigmentosa. So what retinitis pigmentosa is essentially there's mutations in the genes that affect the photoreceptors in the retinal epithelium cells, which leads to presentation with night blindness and then a gradual loss of vision from the periphery of the visual field into the center. Signs that you would see on fundoscopy, and I'll show you these in a minute: bone spicule retinal pigmentation, arteriolar attenuation, and a waxy optic disc pallor. Don't worry, I'll explain all of those with a visual aid in a minute. So investigations that we're going to perform: an electroretinogram. So that's essentially like an EEG that you do for epilepsy, but with the eyes. You're looking at the potentials that are produced in the eyes, and essentially there'd be reduced electrical activity. Perimetry, that's posh word for just formally assessing your visual fields. So you'd find loss of the peripheral fields, known as ring scotoma. Genetic testing, if you are suspecting a diagnosis, they've got all the right signs and symptoms, you'd test for the genes that are known to cause it. And ocular coherence topography that we talked about earlier, when we were talking about AMD, you'd do like a side profile of the retina and you'd see cystoid macular edema. It's just knowing these terms and kind of linking them together. So if you see cystoid macular edema on OCT, if that's in a finals question, right, that's retinitis pigmentosa. Okay. In terms of management, all you can really do is use visual aids and then treat the complications that ensue following diagnosis. So complications are cataracts, which we know we only treat when it starts affecting quality of life, and then we perform surgery. And this cristoid macular edema, essentially you can give carbonic anhydrase inhibitors, which stops the buildup of this edema and reduces this edema in the macula. what causes retinitis pigmentosa. So it's essentially, it's a genetic condition. It's a mutation in the genes that produce the photoreceptors of the retina. So here's a funky fundoscopic image of someone who's got retinitis pigmentosa. Ignore the funny colorings. I'm not quite sure why it's green. The bone spicule retinal pigmentation is this dark thing that almost looks a similar sort of pattern to that dendritic ulcer that we were seeing, but obviously it's on the retina. So that's the bone spicule retinal pigmentation. Arteriolar attenuation. I hope you can all agree that based on previous fundoscopic images that we've seen, these arteries look pretty small, spidery, narrow. They're not very chunky. There's not very many of them. Okay, so that's the arteriolar attenuation. And then the waxy optic disc pallor. Can you see that we can almost see the grain of the retina? I don't quite know how to call it. And that's the waxy optic disc pallor. That's because of ischemia to the retina. Uzair has asked a very interesting question of how is this distinguished from the retina of an African or Asian person? I've got to be honest, I could make up an answer to that, but I would be lying. I did not know there were any differences in the retina of an African or Asian person. Uzair, what differences would you see in the retina of those people? I will await an answer. We'll all wait on tenterhooks. Okay. Final question. Oh, okay. Their retina might be darker than the normal red retina. Let me just go back. Sorry. What you're actually seeing. So this green color isn't necessarily the color of the retina. What you're actually I think there's been fluorescein dye and then we're looking into the back of the eye, or there's been some sort of color change. But what you're actually looking for is a more pale retina, that you can sort of see the underlying structures under the retina. I don't know if you can convince yourself that there's orange lines kind of coming through this green bit of retina. That's the underlying structures under the retina because you've got pale retina, and then the optic disc is quite pale as well. I hope that makes sense. I don't think the retina is darker in retinitis pigmentosa. We've just got these spidery bone spicule pigmentation bits. Okay. Final question. A 56-year-old male has got double vision. This is how his eyes look, and both pupils are reactive to light. What's wrong with him? Okay, so most of you have gone for B, and that is correct. So here's just a summary table. I have referenced this in the notes. I've stolen it from the BMJ, but I thought it was quite a good summary, and I won't sort of go through absolutely all of these presentations for the cranial nerve palsies. You'll be sent the slides if you fill in the feedback, so you can go through it in your own time. But essentially, specifically cranial nerve 3, it's got parasympathetic fibers that run around the outside of the nerve, whereas the blood supply to the nerve itself comes from almost within the nerve. So if you've got just an aneurysm or ischemia or microvascular disease that might be caused by diabetes, you're not going to actually affect those parasympathetic fibers that run around the outside of cranial nerve 3. And it's those parasympathetic fibers that control the sphincter muscles of the iris and control, you know, whether it dilates or constricts. So you won't get any pupil involvement if it's just an aneurysm or ischemia. But if there's compression, for example, a tumor that's properly compressing from the outside, you're going to get pupil involvement as well. Okay, so That's why the answer was there was no parasympathetic involvement, because his pupils are reactive to light. Okay. Thank you so much, guys, for all of your interaction and staying with me, participating in the polls, keeping active on the chat, and keeping Katie busy on the Q&A.
Questions I wondered if we could answer live, if you've got another 5 minutes.
Yeah.
Is that okay? So there was one about just running through the difference between pre-proliferative and proliferative retina.
Yeah, sure.
That's easier with the pictures.
Yeah, just give me a sec. I'll try and zoom back through. So essentially, the big difference in proliferative, you're seeing all of the stuff that you're going to see in pre-proliferative, but there's going to be neovascularization. Okay, so that's why all of these sort of fluffy, spidery little vessels that are coming out the center and all around here that you're not seeing in this image, that's the neovascularization that you see with proliferative diabetic retinopathy. But you see all the other signs, so the hard exudates, cotton wool spots, the dot and blot hemorrhages. You're going to see all of those signs on proliferative as well, but the difference is the neovascularization.
Just a quick question about diabetic and hypertensive retinopathy presenting the same way. So my understanding is that they are very similar, but generally hypertensive retinopathy is more like to do with the vessels. So you can get kind of arteriolar narrowing and things like silver wiring and copper wiring. You can get nipping of the arteries and veins, which you don't get as commonly in diabetic retinopathy. And then you'll go on to, like, in end stage hypertensive retinopathy, get things like flame and blot hemorrhages and papilledema as well. So there are differences, but they're subtle. So I guess it would be good to make sure that you clarify the two things before your exams.
Yeah, and I think they'd be unlikely to give you a fundoscopy image, of something that you could very easily interpret as either a stage of diabetic retinopathy or hypertensive retinopathy with no clinical background and no clinical context to you. That would be really, really harsh.
Yeah, I agree. There's one more question that I answered, and then I worried that you would know more than me. So I just wanted to just quickly clarify just about orbital cellulitis. I initially answered someone answering this question because my understanding of orbital cellulitis is that it's almost borderline medical emergency, and would warrant kind of immediate hospital admission and IV antibiotics. You in my head always need to image someone with suspected orbital cellulitis with a CT to make sure that you can identify the extent of invasion of the infection, and you wouldn't just treat with antibiotics and hold off imaging. You can start empirical IV antibiotics and image and wait for the CT, but everyone should have a CT to make sure that there's no abscesses, which sinuses are affected, if any, and you can see if it's got any intracranial extension.
So this is where practice in reality differs from the NICE guidelines. I think if anyone presents to A&E with orbital cellulitis, they're getting a CT, whether the NICE guidelines say so or not. But the NICE guidelines actually say you only need to image if they're not responding to treatment after, I think it's 36 hours. I think I said 2 days, but it's 36 hours of treatment if there's signs of a complication, or if you can't examine the eye. So according to guidelines, you don't actually need to CT everyone, but I don't think you're going to find an ophthalmologist or an emergency physician in the world who's not going to want to CT someone with orbital cellulitis, because the chance that you might have missed an abscess that needs draining is very high. But according to the guidelines, you only image in those red flags, signs and symptoms not improving, or if you can't examine the eye. But yeah, in reality, you want to CT everyone.
Cool. Yeah. And someone's just asked, do you take swabs, cultures or samples for orbital cellulitis, or just treat with broad spectrum? You would take swabs, cultures and samples and treat with broad spectrum antibiotics while you wait for them to come back, because they're going to take minimum 24, 48 hours to come back.
Yeah, absolutely. Just treat them. But yeah, also take swabs and things. Cataract surgery, phacoemulsification. So essentially you make a cut in the side of the eye you're going to get ultrasound beams, and what they do is they vibrate and shake up the lens that's currently in the eye. It squashes it down into little bits, and then you have a tiny little cut in the eye. You go in and you extract all of that broken lens, bring that out, and then you put a new lens in. And that's essentially it.
Thanks so much, guys, for coming. Don't forget to fill out the feedback form so that you get the slides and the recording as well. Have a great rest of your evening if there's no more questions.
I'm just going to answer, what does 6/7.5 mean? So on a Snellen chart, you'd obviously measure, the top number is you at 6 meters looking at the Snellen chart. The bottom number is what a normal person can see from 6 meters away. No, from a normal person can see that line at that measurement. Sorry, I'm describing this really badly. But essentially, you can see at 6 meters what normal people can see at 7.5 meters. So it means your vision is slightly worse than usual. I'm sure if you were being assessed for a lorry or bus visual assessment-y thing, they'd have a special Snellen chart that probably has the 7.5 reading on it. But on a normal Snellen chart, it doesn't actually have the 7.5 line. It goes in different denominations. Yeah, sorry, I've probably explained that really badly. Katie, is there any better way you can describe what a visual acuity of 6/7.5 means?
I don't think I can. I think I get when it's like over 12 and that people can see the distance at 12 meters, and that if it's 6/12, then you'll have kind of 50% of your acuity of a normal eye. If it's over 7.5, then I guess you would say 7.5 meters is the vision that a normal person would see at. Is that right?
Yes, yeah. So it's essentially, if you have 6/7.5, you have slightly worse than usual vision, because normal people can see it at 7.5 meters and you can only see it at 6. But essentially, on a normal Snellen chart, there's a line for 6/6 and there's a line for 6/12. And if you were between those two lines, there's probably charts that can do the in-between readings as well.
Yeah.
Hopefully that answers your question.
Just with regards to last week's slides, we asked the committee member whose role it is to send them out. She's actually on holiday abroad at the moment, but she's pretty sure she sent them out before she went away. She's coming back on Sunday, so she'll be able to check then. If she hasn't sent the slides out, then she'll send them out on Sunday. And if she has and you haven't got them, then just email us after Sunday and we'll be able to send you the slides. Cool.
Great. Thank you so much for coming, guys. And we'll hope to see you next week on Thursday.
Bye.